topic that is very near and dear to my heart, and it was going to be a review on the one regarding left main disease, but I decided that I was going to do this different article, so because I think it's just a little more comprehensive, frankly. And you have the clicker? Thanks. Merci beaucoup. Sure. Okay, so long-term outcomes after off-pump versus on-pump coronary artery bypass surgery, grafting by experienced surgeons. That's okay. Thank you. Our vast studio audience had their sound up on their recording device. You can watch it live. You don't even need to see it. But thank you. Yeah, I appreciate it.
I was trying to send the link out.
Oh, thank you. So this is out of the Journal of the American College of Cardiology in 2018. So it's actually less than a year old. So let's go to the abstract first. So the background, long-term benefits of off-pump versus on-pump coronary artery bypass grafting are controversial, to say the least. And I'm not going to go over this entire abstract. I'm only going to get to the objectives. The authors sought to compare long-term survival and morbidity after on-pump versus off-pump CABG. So let's look at the study design. It's a retrospective cohort analysis. CABG patients on or off pump between January 1st, 2005 to December 31st, 2011. So roughly 6 years, or 6 full years. So the registries that they used actually are from New Jersey, and New Jersey has a mandatory registry of cardiac surgery that started in 1994. This is very important because I think it's much more, because the STS is voluntary.
New York and New Jersey, they have mandatory registries.
New Jersey is mandatory, okay, very important.
Registers.
It's maintained by the New Jersey Department of Health, and the registry collates data collected by trained clinical staff at each participating hospital, conducts data audits quarterly, and employs external medical auditors to verify data annually. All licensed state hospitals are required, this is very important, required to submit data on each cardiac surgery patient without exception. And therefore, this clinical registry captures all CABG surgeries occurring in the state. Again, I have to say, the STS, although they have a great database, it's voluntary. Not every hospital is part of the STS database. The study population is isolated CABGs, no redos, exclusion, in fact, redo, any hemodynamic instability, need for inotropes preoperatively, or emergency status. So those are all excluded from the pool. The only thing that's in there is elective, isolated coronary artery bypass. First operation, no redos. So the surgeon criteria was designed to reduce the effect of differential expertise bias that you see in expertise-based randomized controlled trials. The surgeons must have performed at least 100 cases of the relevant procedure, on-pump or off-pump CABG. 49 of the 83 off-pump surgeons were selected, and of those, the median number of CABGs those surgeons completed was 905, so that's a fairly experienced surgeon. And at least 79, or I'm sorry, a median, not at least, 79 median within the last 365 days of the study period. For the on-pump, 71 of the 86 were selected with a median number of 935 CABGs, and within the last 365 days, the median was 137. Study endpoints were the primary endpoint was all-cause mortality. The secondary endpoints were stroke, MI, repeat revascularization, and new renal failure requiring dialysis. The same criteria we see on every study. These are the things that are important to us. Did the patient live or die? Did they have a stroke? Did they have an MI? Did they need reintervention? And did they have renal failure requiring dialysis? Of course, the STS, their definition of acute renal failure, I think is extremely tight. You know, to say that a 0.5 jump in your creatinine level, I think that's what it is defined as renal failure. I think it's a bit much. But, you know, they're pretty tight on it as far as I know. So I think it gives a skewed number of the actual renal failure. You don't need dialysis or you don't need some kind of intervention and it corrects itself. I could see calling it AKI. I have a hard time with it being called acute renal failure or new renal failure. So we can look at the demographics here. This is all of the case matching. We don't have to go over it. It's a very busy slide. I just wanted to show it to you, but they looked at socioeconomic and sociodemographic factors, comorbidities, functional and New York Heart Association class, if they had a previous stroke, if they had renal disease, diabetes, smoking history. They basically matched all these patients up, and you can review that at another time when you'd like to. Here's the meat of the matter, however. Long-term outcomes following off-pump or on-pump surgery. Mortality, and this is with a 95% confidence interval, 10-year cumulative event rate. Mortality, off-pump 33.4%, on-pump 29.6%, with an adjusted hazard ratio, again with a 95% confidence interval of 1.11, with the range being 1.04 to 1.18. MI, basically no difference, no discernible difference. Stroke, no discernible difference. Repeat revascularization, 15.4 to 14. That is a discernible difference. And that repeat revascularization was directly contributable to the increased mortality. Here's the graphs. You see ABCD, myocardial infarction, stroke, repeat revascularization, new renal failure requiring dialysis. I would focus my attention, obviously, on the lower left C, and you see the divergence of the various lines favoring off-pump versus on-pump. Long-term mortality following off-pump or on-pump CABG displayed are unadjusted cumulative mortality rates among off-pump, cumulative mortality rates among the off-pump, solid blue line, and on-pump, dashed orange line cohorts, as well as 95% CI. For the confidence interval for cumulative mortality, the shaded area, is calculated by these various Kaplan-Meier analyses. The point here is you can see clearly, focusing in on the years, that for the first 6 months, probably pretty close. Even 1 year still favors on pump. But at year 8, 9, and 10, there's a significant increase in survival when these procedures are done on pump versus off pump. And a lot of the reason for this has to do with the quality of anastomosis and its ability to stay patent. Incomplete revascularization was a huge problem, and those things contributed, in other words, the need for reintervention because of either incomplete revascularization or the grafts going down, were significant contributors to patients' mortality increase in the off-pump group versus the on-pump group. So some key points. Risk of late mortality was higher in the OPCAB group. We saw that. OPCAB had a higher risk for repeat revascularizations, either reoperation surgically or PCI. OpCab had a higher risk of incomplete revascularization, which was an independent predictor of late mortality. No significant differences were seen between the two groups for stroke, new renal failure, or MI. Survival effect with off pump was consistent, or actually survival lack of good effect, it's a mortality effect, if you will, was consistent irrespective of as treated or intention to treat across all surgeons regardless of experience or preference. And what that means is, was the patient treated on pump or off pump or intended to be treated on pump or off pump and then converted from off pump to on pump, and it was consistent across all patient groups, including elderly and patients with low EF. Because I hear this all the time. Surgeons say, oh, the patient's got a real low EF, and I just don't think it's a good idea we put this patient on pump. That's the patients you should put on pump, so that you don't beat the heart by obstructing it, obstructing flow, doing all these manipulations with it while you're trying to do the anastomosis. You don't have to clamp it and plege it, but go on pump, support the circulatory system, let the heart relax, be beating and empty, and then you can manipulate it all you want and do really good grafts. Beating heart, on pump beating heart, I think is a great alternative to off pump. I just simply do not think off pump CABG surgery is a good idea, period. And that is not just because of my bias of being a perfusionist. I really simply do not believe in it. I think it is a bad idea, and I've seen it too many times. So there's been 3 large multi-center randomized controlled trials: the coronary, the Roby, and the GOP-CABI. The survival advantage consistently associated with on-pump over off-pump CABG has been attributed to the higher rates of incomplete revascularization. Again, it's consistent with these other studies. And worse graft patency with off-pump compared with on-pump CABG observed in randomized trials and other retrospective studies. Thoughts and questions? It's not a provocative talk, so don't say it is.
It is a provocative talk.
It's not provocative.
All I'm going to answer is, and I'm going to take the pen on my side. Look at the exclusion criteria from the study. I mean, look what they excluded. Reduced the multi-vessel. One, just exclude the whole patients.
Well, the whole point is, the point is that you want to compare on pump to off pump, and when you don't exclude those cases, then the argument is, well, you didn't adjust for these other comorbidities. Let's take a patient, let's take just virgin, first-time coronary bypass surgeries and compare those. So, I mean, are you telling me you're an advocate for, don't make me decide that I can't like you anymore. Ben, what is going on with this is your stepdad. I'm your dad, I'm adopted dad, this is your stepdad.
What I'm telling you is I'd rather do an off pump on a one vessel redo than a one pump fresh virgin chest. If you're like your patient is sick on a balloon pump, I'm okay with doing balloon pump gives you support. So with mechanical support, and I like what you said, beating heart, pump case, much better than just a pump beating the heart, giving 20 syringes of norepi. I know how we sustain this patient's pressure.
I've seen it.
Yeah.
You can create, anesthesia has the unique skill to create an acceptable blood pressure when there is absolutely no perfusion.
And that's the problem, is people lose the differentiation between blood pressure and perfusion. And so I'm okay doing a one vessel on a 90-year-old guy with a balloon pump. I'm okay doing that, one vessel. But doing a single vessel on a 45-year-old who has long to live and a healthy heart, take your time. Do one vessel, do it the right way.
Put them on pump.
Put them on pump.
Now, in that case, without any kind of aortic disease, you probably even want to clamp and stop that heart, because I think, and I wish I had the video. I got my computer stolen. I wish I had this video, but you remember? Where's Vicky? She left. I used to have a video, and it was the same surgeon, the same assistant team. Everybody was the same at the field, even the same perfusionist. Everything was the same, but 2 different patients. But the coronaries were the same size. They were basically matched patients. They were just different. And I filmed him doing a Lima to the LAD off pump and on pump on the 2 different cases and put the videos side by side. He stopped doing off pump cabbage surgery after he saw what it really looked like. And the camera was zoomed right in on it.
You have a moving target.
I highly recommend everybody do that, because there's no way you're going to convince me doing a right while the blood pressure's tanked, your cerebral oximetry numbers, even though I think that's voodoo too, are in the tank, and nothing looks good, and the patient is just suffering, you know. And you're going to sit there and try to fight getting this PDA done. I'm sorry, that anybody thinks that graft has the same opportunity to be patent in 10 years as does a still quiet, dry field that you can hold over and take your time and do that in osmosis. You're not going to convince me otherwise.
I agree with you 100%. And it's the same thing like minimally invasive or maximally invasive. You know what I used to say when I want to go to the pool, let's show everybody my scar.
Yes.
I want maximum invasive. I want everybody to be proud of my scar. I want to take your time, have maximum exposure, do my coronaries, right? Mm-hmm. And it's okay, you know what I'm saying? If I have a little pump head, that's it's okay. I'm a pump head already.
I have pump head and never been on pump.
See? And you know, what's a little pump head that makes you take things lighter?
Yes.
You take things in perspective.
Well, what people think is that you're smart.
Exactly.
When you can't get your words out, they just think it's like, have you ever noticed that these people who are in Hollywood, they started off basically talking normal like we do, basically normal, and then they become superstars. And now all of a sudden, they're like contemplating every last word, and they talk like they're Stephen Hawking's. It's like, look, you haven't changed, okay? Your brain does not get bigger the more Emmys you win. It doesn't work that way, So, thoughts on my talk?
Well, again, I'm.
You have a call?
No,
Check my phone.
Can you go back to a couple slides where you showed the
graphs?
Yeah.
Yes, and so yes, Nirman Chatterjee. How can lactate be unappreciated? Mainstay for microcirculation. I totally agree, but I think that we have become macrovascular thinkers. We're not thinking at the microvascular level as perfusionists. Our flow is good, the pressure is good, everything looks good. My gases look fine for the short time, but the microcirculatory flow is terrible, but I might not see that until after this case is over, and then it's not my problem. Out by noon with no balloon, that's why.
Out by noon, I like the case.
Out by noon with no balloon.
You have to have a sticker. Out by noon with no balloon.
Joe, he makes a good point, and I don't know his first name. What was his first name? But he, when they do surveys, only about 20 to 25%
Nirman.
of perfusionists, Nirman, 20 to 25% of perfusionists are doing lactates on pump, and I would tell you that I've done years of it without, and I've done years of it with doing lactates. You will become a better perfusionist if you simply order the right iStack cartridge that has the lactate on it. It's the same amount of work, and you get your lactates every 20 or 30 minutes. You'll become a better perfusionist. You'll learn some things about what's going on. And as far as microvascular perfusion, if all you're thinking about is macrovascular perfusion, you're stuck in the 70s, because you should be thinking about microvascular perfusion way long ago.
Do you not think that is a common phenomenon with a lot of our colleagues today?
Oh yeah, absolutely.
Or am I? You think I'm just being overly harsh?
No, you are not.
What do you think?
You're right. You're absolutely right.
Mm-hmm. The thing is, on pump, and this is what I will caution everybody about, and this includes in the ICU when the patient's on CRRT, is masking. You can have a rising lactate but based on your fluid administration at that time that you draw it, will have a profound effect on masking a potential problem because you're diluting it out. There's in the ICU, a decreasing creatinine is actually an indicator of renal failure, because what you're doing is you're flooding the patient and it dilutes it. So CRRT will clear it. Ultrafiltration will clear small molecules, and lactate is very small. So if you're doing any kind of zero balance ultrafiltration, you will clear the lactate and you think all is good, but it isn't.
But you see, the lactate, you look at the trend. Single number in lactate is not good. You have to look at the trend. And you actually, there's some, equipment, not sophisticated, very easy programs that map it out for you. And you'll be amazed with the trend.
Yeah, that's right.
Very important.
And-
I think it's the window into the microvascular perfusion, and what's important is that's what we really need to be looking at.
And I can tell you too that people who use a fair amount of neosynephrine on pump, whether it's a drip or boluses or sometimes both, if you run your lactates, you will see that as you use past a certain threshold of neo, and as you get past it, your lactates will begin to climb. And nothing else changes on perfusion, except you'll notice that as you give excessive amounts of neo, your lactates will also climb, which is telling you something. So I was saying before, if you want to become a better perfusionist, run your lactates with every blood gas.
I agree.
Joe, can you go back a couple slides to the...
Yeah.
Because I wanted
Can you go back a couple of slides?
It showed your graphics, and I was not sure what the
And
repeat...
Neerman says that he's a consultant intensivist.
Okay.
Dealing with ECMO and lactate helps him tremendously.
Oh,
I
yeah.
think every patient on ECMO should have lactates done at least Q6. Maybe you could do, if it's stable, Q12. If you have an issue of any sort, Q6.
Just add it to your labs. It's not that expensive test.
Yeah.
It's true.
Add
too.
it to your labs.
I agree.
So you're saying that 15 point, maybe it's the one before, but repeat revascularization, off pump 15.4, on pump 14. Maybe it's the one before this.
Go
We
before
actually-
that.
I don't know. But
Oh, here.
What
I've
were
got
the
the
units?
clicker.
What were the
Hold
units
on.
of measure?
You
What-
mean
yeah,
here?
that percentage?
Repeat
What is
it.
that? Yeah. Repeat revascularization 15.4 and 14. What is the unit?
Yeah, it's a percentage.
So 15.4% of off pump patients had to be revascularized.
Right. See, 10-year cumulative event rate percent.
And only
Right.
14% on pump.
Right.
Okay.
So your need for some type of reintervention, if you had it done off pump, was 15.4%. If you had it done on pump, was 14%. And that reintervention was mostly, if you look at the next line down, PCI, which was 14.7, in fact it was all of it, to 13.3. Cabbage was 0.9 on both arms. So you actually had operation for your to redo the graft. Most of them were handled in the cath lab, and probably what they did is what you see a lot of now, which doesn't make sense to me, but they do these hybrid procedures. They'll do the LAD off pump single vessel mammary, and then they'll go to the cath lab and they'll do the stent of the right and maybe the circ or the OM or something like that they can get to, or diagonal possibly. I don't know how that makes sense, because then you look at the data and PCI
Is inferior to.
is much inferior. And your 5-year need for reintervention with PCI is incredibly higher than that for coronary bypass on pump. And I think that's a delineation I think that is, look, off pump cabbage got up to 23%. It's maybe down to, it's under 10. It's down to maybe 7, 8% now. There's a few holdouts that are still doing them. I know one of them. And every off-pump surgeon believes wholeheartedly in their heart of hearts, deep in their soul, that they do it just as well as anybody else that does it on pump. And, again, I'm not trying to be overly provocative, but I would be happy to have any discussion with them. I'd be happy to film their procedures. I'd be happy to look at the data with them. And there's just such a cornucopia, if you will, of data that just starkly says otherwise. And that's my concern. Why are we still doing this? Should have been one of the controversies.
One thing I've always wondered is when you're with, let's say you're off pump and you're doing an LAD distal graft, what is the ischemic time and what is the ischemic effect post where you're working? Because a lot of people have a probe occluding the flow, right?
Well,
Or-
sometimes they put shunts in.
You can
They
put shunts in, yeah.
Yeah, sometimes they put shunts in. Of course, if you got,
Yeah,
I
there's
mean, yeah,
I'll tell you, interesting, this is not off pump necessarily, but I worked with a guy, elderly, very experienced surgeon, and what he would do is go on pump with beating heart and use the off pump retractors.
yeah, that's what I said.
And do what he could do.
listening.
Yeah.
No, I heard, but well, I thought you meant totally off pump and then go on pump later.
No, go
he would be on pump, yeah.
and do it with the
Well,
stabilizers.
Then the difficult
so you're
vessels,
doing on pump.
he would
beating
go
heart.
ahead and cross clamp and plege and do the difficult vessels as a regular cross clamp. So what he could get away with beating heart, he would do all the same procedure, and then he would, like back of the heart and things, he would call up and plege. So your cardioplegia time was much less.
Give Del
But-
Nito.
So.
You don't need to worry about it anymore.
But the thing about that is you're spending a lot of money because the expense for the retractor of the off pump.
Oh, and I
is
think
like-
I know. Well, you know what?
and you're still on pump.
It costs more than more than the pump.
Yeah.
I mean,
yes.
the off pump retractors cost more than the pump the oxygenators.
Well, I think there are a lot
You know
more.
what I
Many
like to
times
teach
more.
the residents sometimes? Once you put the heart down after like it has been up and pressure is 0, get an ABG right away.
Yeah.
See how bad it is. That teaches you how acidotic you are, how you're not perfusing.
Yes.
And I mean the magnitude of drama. Then get an ABG right away so you can see that I'm not making this stuff up. It's real.
Yeah,
Absolutely.
Yeah.
But to your point, John, wouldn't it be great if you could do it? If it was, I mean, I'm sure somebody has done it probably, but stick a catheter, stick a retrograde into the coronary sinus, and while they're doing that off pump, draw serial coronary sinus gases
Yes.
and see what it is.
Well, that's what I was saying. Shunt or no shunt or whatever. You have to think that if it's 12 or so minute distal, that the area they're working is
Absolutely.
probably hypoperfused, if not,
Yes.
But
Not to mention, I'm telling you, I've just, you got to look at the video. You got to really watch somebody doing an off pump.
what was the key difference? I'm curious. I didn't.
Everything, precision.
Precision,
the
location of the stitches
the depth
and-
of the bites, the spacing, I saw him go in and then out, in and then out, in and then out, and then finally get it. I'm like, what the heck are you doing? I mean, you're chewing that poor vessel up.
Was that because of the movement or,
Yes,
or because of
the
the flow? There's always
Movement,
blood.
they're blowing with the
right,
blower,
and it's distorting.
And actually, it was at your place. I think it was Dr. Garami who they were doing an off pump cabbage, and with your off pump surgeon, who I like personally, he's a true gentleman, but I disagree with his philosophy on surgery. I wouldn't go to him and have it done off pump. I don't care how good he thinks he is or how many he does. I'd go someplace else. I'm getting put on pump. That's it. But
As controversial as you want
they
right
were-
now, you're really controversial.
I'll go right out there. I'm going out there. So that he would use he was using the CO2 blower to clear the field, and the not cerebral oximeter, the transcranial Doppler was going off like crazy. And they finally realized, well, move that thing. They moved it. It went away. Put it back. Put it back. More bubbles go into the brain, CO2 bubbles. So, these things are just not without consequence. And you don't even think about that. But it can do that. You can shoot it right up the coronary, out into the aorta. The heart's beating, goes straight to the brain. That's problematic, even if it is CO2.